cyanotic heart disease or right to left shunt. In acyanotic heart disease, blood from the left ventricle, that is the oxygenated blood from the left ventricle, goes into the right ventricle, that is the deoxygenated blood, whereas in this condition blood from the right ventricle goes into the left ventricle, which contains the oxygenated blood, and this will lead to the deoxygenation or mixing of the pure blood that is supplied to the systemic circulation or into the body, and this will lead to the central cyanosis, and this will also reduce the pulmonary blood flow in most cases like tetralogy of Fallot. Now the some examples of cyanotic congenital heart diseases are the tetralogy of Fallot, transposition of great arteries, total anomalous pulmonary venous return, tricuspid atresia, and abstain anomaly. Now let's know briefly about the tetralogy of Fallot. It is the most common type of cyanotic congenital heart disease. It is the most common type of cyanotic congenital heart disease, and it have four components, that is the VSD, as we can see in this image, VSD, ventricular septal defect, then pulmonary stenosis, as we can see here, there narrowing of the pulmonary artery, then overriding of aorta, as we can see there is overriding of aorta, and hypertrophy of the right ventricle. So these are the component of tetralogy of Fallot, and due to the pulmonary stenosis there is increase in the right ventricular pressure, and this will lead to the blood shunting from right to left. So what happens, due to this stenosis, blood from the right ventricle shunted into the left ventricle where it contains oxygenated blood, and then due to the mixing of deoxygenated blood into the oxygenated blood, this will lead to the cyanosis. Clinical presentation of this is the TET spells or hypercyanotic episodes. Now the transposition of great arteries. As its name suggests, there is swapping of the pulmonary artery and the aorta at its origin. So what happens in normal? There is a pulmonary artery communicates with the right ventricle, whereas the aorta communicates with the left ventricle. And then pulmonary artery carry the deoxygenated blood to the pulmonary system, whereas the aorta carries the oxygenated blood to the systemic circulation or to the body. What happens in transposition of great artery? There is swapping of pulmonary and aorta. So what happens? Aorta carry blood from right ventricle to the systemic circulation, deoxygenated blood, whereas the pulmonary artery carries the oxygenated blood. So this will lead to the early fetal life or neonatal life cyanosis, and this is incompatible with the life. So for the survival of the neonate, there should be the mixing where ASD, BSD or PDA is required, and it is of two types, D types and the L loop types. So this condition is the D type, whereas in the L type is the congenitally corrected TGA. So L type is called congenitally corrected TGA. What happens in L loop transposition of great arteries? Here we can see two images, that is the one is the normal heart and another one is the L transposition of the great arteries. So this is the congenitally corrected. So what happens in this? There is both atrioventricular and ventriculo-arterial discordance. That is the atrial and ventricular arterial discordance, accompanied by usually normal drainage of systemic and pulmonary vein to the right and left atria respectively. So what happens? There is discordance of the atrial and the ventricular arterial. So this will lead to the normal circulation to the body. So what happens? The deoxygenated blood returning to the right atrium. This is the deoxygenated blood returning to the right atrium, drains via the mitral valve, that is this is the mitral valve, into the morphologic left ventricle. So this is the morphologic, as we can see that the smooth wall. So this is the morphologic left ventricle, and which supplies the pulmonary artery. So this is the pulmonary artery. Pulmonary artery supply from the left ventricle, and then this deoxygenated blood goes into the lungs, whereas the oxygenated blood from the pulmonary vein enters the left atrium. That, as we can see here, these are the pulmonary vein, blood drain into the left atria. These are the oxygenated blood from the lungs, and this drain via the tricuspid valve into the morphologic right ventricle. So this is the morphologic right ventricle which drains into the aorta and then supply to the systemic circulation. So this sequence is compatible with life. So this is called the congenitally corrected, as the phenomenon of the double discordance allows blood to flow in the normal direction while passing through the reversed ventricle in the process. Another anomaly is the anomalous pulmonary venous return. It is of two types, total and partial. So in total anomalous pulmonary venous return, all systemic and pulmonary vein drain into the right atrium, that is here, and nothing drain into the left atrium. So left atrium is empty, nothing drain into the left atrium. So for the survival of the fetus or neonate, there should be patent foramen ovale, or there should be ASD, atrial septal defect, is required for the survival of the neonate. So it is of four types depending on the drainage of the anomalous pulmonary vein. So type 1 is the supracardiac type. It is the most common type which is seen more than 50% of cases, and anomalous pulmonary vein form a left vertical vein. This is, we can see here, left vertical vein which drain into the brachiocephalic or superior vena cava or azygous vein. So this is the type 1 and it is the most common type. Another one is the type 2, that is the cardiac level, and it is the second most common type and it is seen in the 30% of cases. So pulmonary vein connect at the cardiac level, that we can see here. So drain into the coronary sinus of right atrium. So we can see here, that is the anomalous vein drain into the right atrium via the coronary sinus. Now type 3 is the infracardiac type, where connection at the infracardiac level, as we can see here, that is the inferior vena cava in this image, and it can drain into the hepatic vein, portal vein or IVC. Now type 4, this is the mixed pattern, so it could be supracardiac or infracardiac type or the cardiac type. Now let's know briefly about the partial anomalous pulmonary venous connection or return. So this is the acyanotic condition, whereas the total anomalous is the cyanotic condition. So in this part of the, not all, few pulmonary vein drain into the right atrium or systemic vein instead of the left atrium, and it is essentially a combination of pulmonary hypoplasia and partial anomalous pulmonary venous return. It almost exclusively occur on the right side. So it is mostly seen on the right side. As we can see, the anomalous vein can drain into the superior vena cava or into the inferior vena cava or coronary sinus. As we can see here, this is the coronary sinus, inferior vena cava or superior vena cava. It is most commonly on right side, but it can also seen on the left side. Now the Epstein anomaly. It is a rare congenital heart defect where the tricuspid valve is malformed and displaced downwards into the right ventricle, causing severe leakage or regurgitation of blood from the right ventricle into the right atrium and lead to the enlargement of the right atrium. So there is insufficient heart function and this will lead to the cyanosis due to the low oxygen level. Now the high yield exam points are: the most common congenital heart disease is the VSD or ventricular septal defect. Most common cyanotic congenital heart disease is the tetralogy of Fallot, whereas the early cyanosis in newborn is the, think of, transposition of great arteries. Long standing left to right shunt will lead to the Eisenmenger syndrome, which is irreversible condition. Now these are my references, and so we understood the core pathology of congenital heart disease, the difference between the cyanotic and cyanotic lesion, and how shunt direction determines oxygen saturation, and how long-standing defects can lead to complications like Eisenmenger syndrome. So in the next video, we will move from theory to imaging and discuss the radiological manifestations like chest X-ray findings and classic specific signs of congenital heart disease. So subscribe my channel to make sure you watch next video to connect pathophysiology with imaging, because in radiology understanding physiology makes image interpretation more easy. Thank you.